Professor Trudeau, in this molecular era, what do you think are the main challenges we face in relation to cancer clinical trials?
In the molecular era, what we're looking at is, rather than specific tumor types, is a heterogeneity within tumors and maybe more pathway-driven treatments. And so we need to find out what are the molecular profiles or the molecular markers that predict for a drug to be successful in a specific tumor as opposed to a specific tumor type. So more personalized. And that of course brings up the issue of what are the markers, how do you define them, how are they tested, how are they validated, and then how do you test them in clinical trials along with the patient and the drug, say, that you're putting it together with, to see what's most successful. And there are so many new drugs, there are so many pathways, there are so many molecular markers. How do we do that in a concise way that is actually cost effective?
And if we look in breast cancer, obviously we've gained significant knowledge on the biology of breast cancer, the pathways that you mentioned, in the last number of years. But how do we translate that knowledge into meaningful clinical trials that will have real benefit for breast cancer patients?
Yeah. Well, I personally believe that the day of large phase 3 clinical trials has probably come to a standstill, and that we're going to be looking at different ways to do our trials, either window of opportunity trials where a drug is tested prior to surgery, or in the neoadjuvant setting. And in the neoadjuvant setting, we can test a marker plus the drug along with standard therapy, see whether pathological complete response could be used as a surrogate endpoint, which many would argue it could, and then take successful drugs and their marker forward into phase 3 trials.
And in relation to that, you're obviously starting to look at the area of companion diagnostics in relation to the drug. Do you think we've developed companion diagnostics to a sufficient level that they can actually be used reliably in phase 3 clinical trials?
That's a very good question, and I would say the answer is no. There are many different molecular assays, and there's continually new things being looked at. We need to be able to have studies where we actually look at what is the best companion marker for that drug and what's the best subset. So that's very complicated, and I like the I-SPY 2 challenge, where they're actually looking, in the US, looking to see if you can pair the marker with the drug in a specific subset and compare many things at the same time in different areas, maybe different centers doing different parts of the trial, and then picking a winner and then taking that forward.
Yeah, I think that certainly is a very attractive option. I think it's something that we'd like to see not only in breast but in other tumour types as well. One bottleneck that's rapidly becoming evident, and particularly if we compare in the United States and Canada with in Europe, is access to innovative drugs in the context of clinical trials. What do you see as the particular problems that limit access to new therapies?
Our access to therapies are coming from either pharma, including startup venture capitalists, I guess, or from cooperative groups. The problem with cooperative groups is the lack of funding to actually sustain many trials at the same time. And I don't see that getting better anytime soon. I think what we need is more collaboration around how we're, with different pharma companies, how are we going to get these drugs and these markers developed, how we get them out so that, in particular in breast cancer, women will get the benefit faster.
And we see differences or variability in reimbursement of cancer drugs, particularly by publicly funded programs. Is this a real problem first? And secondly, how do we address this problem?
Well, that's a complicated question. It is a problem. It's a problem, I guess, on all levels, and also it goes to rationing, or what is the value for money, and should every drug that's tested be used, or should every drug that looks promising really be taken forward? So what we really want are the best drugs that give us the best advantage, or, I mean, what we have never done is replace old treatments with new ones. We just add them on. So I think that there needs to be a cost effectiveness analysis. There needs to be some way transparently looking at what value we're actually getting for the new therapies that we're developing. But because it's so different in, say, Canada, right next to the United States, where everything is approved, everything can be used, if you have a third-party payer, where in Canada you've got the government as the primary payer and more restrictions on what drugs are available. I think if we can look at the outcomes in the different countries too, to see if there's any differences, to make that argument that maybe you don't need access to every single new therapy, and what we need are the best therapies that are most effective.
And balancing that with sort of health technology assessment is a difficult thing to do. Obviously,
Yes.
we have the issue in relation to access to the therapies, but then also whether those therapies, as you say, provide economic value as well as value for the patient. In that regard, do you see that we need to think about different ways in which we do clinical trials in the future?
I think if we can make our trials faster, more efficient, cost-effective, that would certainly help. Involving more people in the community, trying to actually increase accrual, would also be another way to try and get trials done more quickly. I mean, right now, 5 to 10% of patients actually are enrolled in clinical trials. How can we make the clinical trial more appealing to the patients so that they're encouraged and maybe even rewarded in some way? Maybe their parking is paid so that they would actually be on the trial. And the other area is extending the group of people, particularly women in breast cancer trials, who are eligible for trials. Many minorities, non-Caucasian people, are not in clinical trials, and that's 90% of the world. So how do we get those patients into studies, make sure that what we do is generalizable?
Yes, no, I think that is a significant challenge. We have been successful in relation to improving treatments in diseases like breast cancer particularly. We now start to see a significant cohort of cured patients. How do we ensure that quality of life issues are addressed in a satisfactory fashion in this rapidly expanding group of long-term survivors?
That's another area of challenge, and one that I guess we're all grappling with, is who is the best care provider for the woman who's had breast cancer and is a survivor? And should it be in the cancer center? Should it be with the family physician? And in our own experience, I don't think we've done a good job with our survivors. There's lots of issues: bone health, cognition, many aspects that are not well appreciated and which we haven't gotten the patient feedback on either. So in our own clinics, we started doing ESAS, which is a patient-reported outcome, Edmonton Symptom Assessment Scale, at every visit, from the time that they're diagnosed through to the time that they're leaving the clinic as a survivor. And that helps address issues around anxiety, around family, around more of the social issues which need to be looked at for these women. And also, I think when we do transition back to the care of the family doctor, because you can't have this increasing number of survivors in all areas of cancer looked after in the same institution with the same level of care as all the people who are currently going through treatment. So we have to figure out how those women want to be followed up. Is it a phone call? Is it a visit? Is it a well-woman visit to the family doctor who will make sure that bone health is looked after, that she gets all of her screening tests, including colonoscopy, rather than piecemeal as we've been doing it to date?
Certainly, that sounds a very interesting approach, and one that we need to look at further in the European context. Dr. Trudeau, thank you very much for your time.
You're welcome. Thank you.